population with a waist circumference of 105 centimeters. So we have central obesity and obese subjects with all cardiovascular risk factor or a cardiovascular disease had been enrolled. Looking at baseline other parameters, you have a systolic blood pressure of 135, diastolic blood pressure of about 77 millimeter, and a normal heart rate. These are all baseline characteristics, fairly stable on all cardiac medications, being treated by many are being treated by cardiologists and what kind various interventions done, and receiving constant cardioprotective medicine. And it is in all three groups, not in particular one group. All three groups receive same cardioprotective medicine. So one shouldn't interpret that one group received one and something more than the other. Looking at further findings beyond systolic blood pressure, we now look at lipid parameters. And if you see, as these are all CV patients, LDL cholesterol of about 85, which is a good achievement for most diabetic people, exactly between 70 and 100, HDL cholesterol of 44, eGFR of about 74, and this is a split between absolutely normal GFR, this is stage 2, 60 to 90, and then this is below 60, 26%. And you might recall below 30 eGFR were excluded. There would be probably an interesting finding between 60 and 45 and 45 and 30 in terms of getting different results in different stages of eGFR and chronic kidney disease. Looking at the pattern of cardiovascular disease in these patients, any CV risk factor, practically all of them, coronary artery disease 75%, multivessel 47%, history of MI in 46% of patients, intervention by bypass was done in roughly 1/4 of patients, stroke were about 23%, peripheral arterial disease about 20%, single vessel disease, and most importantly, our attention goes to heart failure in all CV outcome was present in just 10% of people. They were not highly advanced cardiac disease patients, but there were 10% who had history of heart failure. So MI predominantly, which remains as primary endpoint as we were listed. What kind of treatment these people were receiving prior to and during the study ongoing? Antihypertensive 95%, practically most of them or all of them you could say. ACE inhibitor or ARB, which remains first choice in these people, is 80%, beta blocker 65%, diuretic. There had been a question in the morning, what about diuretic in presence of SGLT2? And you might see 42% received diuretic. CCB 33%, mineralocorticoid receptor antagonist about 6%, and there are others. So predominantly the distribution, probably some of the cardiologists here might feel, may be similar to their practice in non-diabetic or in diabetic, irrespective of the trial, and any of those patients could qualify in their practice for a drug like SGLT2 inhibitor. Looking at lipid-lowering agents, statin 77%, so more than 3/4. Fibrate still has a place to reduce in a CV patients close to 9%, ezetimibe about 4%, niacin 1.5 to 2%, and there are some other drugs. So people did receive, 80% received lipid-lowering agent. We do not know why 20% did not receive lipid-lowering. Anticoagulant, that is rather more of antiplatelet agent in close to 90% of patients. And this is a distribution of 3 different class, but majority received an aspirin as an antiplatelet agent, something similar to practice in most of the clinics. Treatment duration in this particular study was 2.6 years for all this, and an observation period of about 3 years. Not too long, and in this much period of time, we got the results what was expected as so-called event-driven trial to close the trial. And as you see over 206 weeks, what is being plotted as reduction in HbA1c right in the first 12 weeks, the criteria or the mandatory criteria was not to change any anti-diabetic treatment when empagliflozin or placebo was added. And that's the reason that placebo has no significant reduction in A1C, but you find good reduction within first 3 months with empagliflozin, both the doses, and then that particular dose was continued all along. At the same time, please remember that in all such clinical trial, to remove the efficacy or effect of different A1C in both the groups, which has to be eliminated. So a group which received placebo might receive different anti-hyperglycemic medication. And that's the result that finally at end point you may find that A1C is identical in both the groups, even though this group was treated as with placebo. So it should not imply that empagliflozin did not work on long time. Rather, it maintains significantly lower A1C along all these periods, irrespective of what happened to a placebo group. Looking at the change in waist circumference, oh, I missed a slide on weight. What was the change in weight? Again, you find a similar effect. There is a reduction in weight during first 12 to 24 weeks, which has been sustained, or rather I would say that slightly further gradual reduction in weight, which happened over almost first 2 years, 108 weeks. And that loss of weight was persistently maintained. Many people have an implication that initial weight loss then subsequently may result into more food intake, and again weight loss may not get sustained. Rather, here with SGLT2 and EMPA, weight loss was well sustained in most of the patients. And this was not only the water component of the body, but you could see a change in waist circumference as observed from early part of treatment and has been maintained all along. So there is a reduction from 105 to 103, so about an inch or a couple of centimeters, which may translate into a good benefit in long term. A change in systolic blood pressure from baseline 135, which is too good a systolic blood pressure as far as common clinical practice goes, but patients did reduce about approximately 4 millimeter of systolic blood pressure right in the initial part, and which was sustained along the length of the trial. Not only systolic, but there is also a diastolic blood pressure reduction from 77 to about 74 millimeter all along. And there had been all along the difference in blood pressure between all three different arms. There had been many studies with new investigational diabetes drugs, and increase in heart rate is a concern in some of the studies. And you find here that with this empagliflozin, there had been no concern or no significant change in heart rate all the time at every observational follow-up visits. If you look at LDL, you find a small elevation from 86 going up to 90 milligram, about 4 milligram, and then again coming down, matching with placebo at 136 weeks, and finally at a trial and practically identical LDL cholesterol concentration. The change in HDL, here you will find that placebo having absolutely flat curve, and HDL concentration increase with the treatment with empagliflozin, though a small, but it might have a meaning. And if you take now the ratio of LDL to HDL, probably the ratio remain constant all along. With this kind of baseline characteristics and what we found on the most important parameters which are being observed in long-term clinical trial, I would end here, and Dr. A.K. Singh will take over further. Over to Dr. Neglur, please.
The next speaker is Dr. Avdesh Kumar Singh. We call him AK-47. He's like a firing, very sharp and very intelligent speaker. And he is endocrinologist and diabetologist at the GT Diabetes Institute, Kolkata. He's also chief consultant endocrinologist and diabetologist at Sun Valley Diabetes Endocrine Research Center at Guwahati. Dr. A.K., to you.
Thank you very much. Well, so, I would like to thank, first of all, organizer Shailaja and Dr. Madikar for inviting me. This is my opening talks here. I missed in the morning. But then, I will summarize you what Dr. Sanjeev Sir told you, because it's bombarded with the data, and you might have loaded with a number of numerical figures, which might be a little bit difficult for you to understand. But then, first day, first show is always enjoying. probably witnessed the landmark trial in ESD when it was presented. We, Dr. Neglur, many of us were there when the trial was presented first, and if you read into Medscape and you listen into ESD, web stream right now on ESD virtual, you could see the number of applauds coming with the each trial results were when it was, brought out in front of all of us. But then it is always in UKPDS trial we have seen millions of times in every presentation. We never got bored. I think EMPA REG would be a next trial where you will see million of times in future. It's like a movie. When a Three Idiots was, hit movie, I saw probably 11 times. Titanic maybe 20 times, Soleil 50 times. We never get bored. Such a kind of trial is this, that anytime you see, probably you learn something new. So when I saw the first study result in ESD, and then after when I read into NEJM, and then look into the data again, I learned several newer things, which I'm going to share with you. So let me summarize when I'm going to present to you the data in terms of hard endpoint cardiovascular outcome data. What was these trial were all about? This trial it was a glycemic equipoise trial, means you need to maintain HbA1c similar in both arms, in the placebo arm and the empagliflozin arm, but you can't use empagliflozin in the placebo arm. Other than empagliflozin or any SGLT2 inhibitor, you can use anything and everything in the world to make HbA1c similar. In spite of that, if you closely look into a supplementary table in NEJM, there are 15 tables, you could see in the placebo arm, there was 10% rise in insulin, SU, TJD doses compared to the active arm. That gives you a hint that, and I would look into that empagliflozin was one of the robust molecule in terms of reducing HbA1c, that you, in spite of increasing insulin, sulfonylurea, TJD, metformin, you could not achieve a similar HbA1c like in empagliflozin arm, and there was a 0.3% better HbA1c reduction in the empagliflozin arm. So this is one way to look into the study. Second one, 7,000 odds patients, so it's a quite a large study of mean duration of 3.1 years. 50% had more than 10 years of diabetes duration, but remember one catch is there. This is one of the trials similar to the UKPDS, where the 2% of the patients were completely treatment naive. It was never happened in tacozexamine and sebertimi. So you have got a patients where the majority were more than 10 years, but the 2% of the patients were completely treatment naive. So a kind of a, wild variety of case, what you can call. So you have got a varieties of patients included. Second, 99% had a history of known cardiovascular disease, of which 50% already had a history of heart attack. But the patient who had a heart attack within first 2 months were excluded from the study. Gentlemen, you asked this question. So only the EGFR less than 30 was not the exclusion criteria. There were numerous exclusion criteria, of which the most important one was EGFR less than 30, and the second most important one were ACS less than 2 months, which is exactly opposite if you look into Examine trial or you look into ELIXA trial. So this were a little bit different, where their patients with the history of ACS within 90 days were included in the trial. So this is a basic difference. Then what you could do is you could reduce HbA1c of 0.3%, you could reduce systolic blood pressure by 4 millimeter, diastolic by 2 millimeter, you could reduce body weight by 2 kg on an average, and then the question remains is, by doing this, could you do any improvement in the hard endpoint? So my job is to look into what happened into the primary objective of this study, which was a 3-point major adverse cardiovascular event determined by 3 outcomes, one by cardiovascular death, another was non-fatal MI, third was non-fatal stroke. So what happens to the composite of this 3-point mesh? And this is the result. You could see the placebo arm, and this is the empagliflozin pooled arm. Means if you combine empagliflozin 10 milligram and 25 milligram, you could see clearly here the HR was 0.86, means there is a relative reduction of 14% in terms of 3-point MACE outcome. Remember, by this data, by now we understood that a composite 3-point MACE of cardiovascular death, non-fatal MI, and non-fatal stroke combined together, you could reduce by relative risk by 14% in a empagliflozin pool. Now, the study also looked into the 2 different arms, means empagliflozin 10 milligram and 25 milligram. Remember, what was the p-value for superiority? It was p, if the p is less than 0.0498, then this is a superior. Now, this superiority is no more here. When you separate this empagliflozin 10 and empagliflozin 25 milligram, one may argue then, how could you get the benefit? Answer is very simple. When you divide empagliflozin 10 and 25 milligram, you are basically dividing the patient's pool. So in one end, now you are calculating the data in 2,350 odd patients rather than the data of 3,500. So if you pull the data into half, then you have a difference in terms of a statistical significance. But if you combine this data, you could achieve the relative risk reduction of 14 in terms of 3-point MACE outcome. So this is the first out of the composite endpoint. You could see here this is 0.86 hazard ratio, which translates into a relative risk reduction of 14%. Now, let's look into the other composite point, and these are some sensitivity analysis, so intention to treat, on treatment analysis and per protocol analysis. I am not going to details, but there are typical definitions for, but the primary objective were actually to look into intention to treat populations. But if you are again going into a sensitivity analysis like on treatment analysis or per protocol analysis, this is similar if you closely look into versus intention to treat populations. What happened to the other points of outcome in 3-point MACE data? As I said, CB death was 1 point, which we were talking about. Let's see into a different point of outcome out of the composite endpoint. So what happens to the cardiovascular death in the empagliflozin arm? So when you look into the pooled population of empagliflozin 10 and 25 milligram, you could see a robust reduction of 38% in the relative risk. So you could achieve the hazard ratio of 0.62 when the P is statistically significant, thereby suggesting a 38% relative risk reduction. For the first time, you could see an anti-diabetic drug showing 38% reduction in the cardiovascular death in the history and the treatment of type 2 diabetes. When you again analyze this data into whether this has happened to the pooled group or empagliflozin separate arm, now the very interesting data emerged. Whether it is empagliflozin 10 milligram or 25 milligram, you could have a similar statistical significance. You could see here there was a reduction of 35% relative risk in the 10 milligram. You could see here in 25 milligram even further in terms of cardiovascular death. So this is again in spite of division of the number of patients, they could see a statistically significant reduction in cardiovascular death. So when you look into, why not, this is moving, into a simple forest plot to understand, as I mentioned, the 3-point MACE by 14%, the CV death by 38%, very simple way to understand. Then what happened to non-fatal MI and non-fatal stroke, the individual component of this 3-point MACE? Interestingly, there was no difference in terms of non-fatal MI or non-fatal stroke. This is one area where there is some hitches, that there was a disconnect. If we could have achieved improvement in non-fatal MI or non-fatal stroke, then there's nothing to talk about. And in fact, if you closely look into, as a critical analyst, you could find out there is a trend of increase in a stroke, which was not statistically significant. So critics might argue that the drug in question actually increased stroke, non-fatal stroke by 24%, at least there was a trend. But remember, that's the beauty of medical statistics, that it was not statistically significant. So the investigators actually looked into the detail of non-fatal stroke, and I will come back to all this issue. So they closely look into this stroke data, because everybody was concerned about that trend of stroke. Many critics might say that I don't want to make my patients paralyzed because of a stroke, and just in terms of reducing cardiovascular death. What is the point in survival if I develop a stroke? So they looked into the stroke data into detail. So you could see here, this was the intention to treat population, and again this data is not changing. See what happens to the HR here. So what was the intention to treat populations? These were the patients who were actually followed up 90 days after the end of trial. And then this HR was 1.18. And when this were analyzed in terms of on-treatment analysis. What is on-treatment analysis? When the patients were on empagliflozin up to 30 days of stopping the trial. And now see the difference, now see the difference, this HR comes down to 1.04, so from 24% to 18% in intention to treat population, and by only 0.04% in on-treatment analysis. They were suggesting that this signal is not present in reality. One might argue that if the drug in question is increasing a stroke by 28% after this trial was stopped, and you analyze the data up to 90 days, that then I might argue that this was happened because you stopped the drug. The drug might be protecting you. The moment you stopped it, there was an increase in a stroke. So we don't know the exact answer. There may be argument and counter argument. I'm sure investigator must be looking into the post hoc analysis of these data of fatal and non-fatal stroke in details, and we will be able to know in details about all this. So what happened to the 4-point MACE outcome? As Dr. Shailaja told you, the 3-point MACE were CV death, non-fatal MI, non-fatal stroke. If you add unstable angina, then it becomes a 4-point MACE. And moment you add unstable angina, the significance of benefit in terms of 4-point MACE were lost. So you don't get the benefit in the 4-point MACE outcome data. What about the heart failure? Remember, these patients, the baseline heart failure patients were 10% in each arm were recruited in this particular trial, which is almost similar to Saber-TIMI trial. There were 13% patients were having a baseline heart failure in Saber-TIMI. In TECOS, it was 18%. In EXAMINE, it was 23%. So in this trial, 10% patients had a baseline heart failure, and they looked into what happened to the heart failure, including the patients with a baseline heart failure. So this is the data in terms of hazard ratio, see the placebo, and then see the difference in terms of pooled data of empagliflozin 10 and 25 milligram, and the hazard ratio is now 0.65, which is statistically significant and superior, thereby suggesting 35% relative risk reduction in hospitalization due to heart failure. Now, when they analyze the data again in terms of different dose of empagliflozin, now you could see again this, the p-value remains significant, and in fact very interesting data, although we should not read much into this, that empagliflozin 10 milligram is looking better than empagliflozin 25 milligram if you closely look into this comparison chart in terms of the hazard ratio of hospitalization due to heart failure. So this is very fascinating data, happens both with both doses of empagliflozin in this particular trial. Something is wrong, it's not progressing. Well, so the very important point was all-cause mortality. Now, as a researcher and a clinician, many people might argue that a statistician may have capability to twist the data according to their wish. Now, so if you are a simple, a blind shooter, and when you're looking into a trial, look into the all-cause mortality, because for that you don't need any statistical significance. If somebody has died, patient has died. So if any trial gives you a benefit of all-cause mortality, there is nothing for a statistician to tweak the data, because somebody has died and it is died. So if the result has got a benefit of all-cause mortality, then the molecule in question has to be robust, whatever the statistician does it. So what happens to the all-cause mortality in this empagliflozin CV outcome trial? So see here, this is empagliflozin pooled, and so this is the data in terms of hazard ratio, the HR of 0.65, 68, thereby suggesting a relative risk reduction of 32%. P-value statistically significant. So this is one of the first trial where you could see an anti-diabetic agent giving you all-cause mortality in a tune of 32%. And Professor Del Prato will tell you in details about this critical analysis of what happened in this. Again, you are looking into different doses of empagliflozin. You could see a similar benefit irrespective of the dose of empagliflozin, and p-value were statistically significant. Well, so this is in summary of what happened to the all-cause mortality, cardiovascular death, and the non-CB death. So you could see this benefit in this simple forest plot, what I talked about. Now the biggest question was when actually we knew this trial result, when it was, the first headline result came on 20th August, we could closely looking into what happened in terms of safety, because we might get benefit in terms of cardiovascular outcome, but what about the safety? Remember, before that we had all, issues of diabetic, euglycemic diabetic ketoacidosis by FDA alert or by EMA alert. So we were closely looking into this safety data, and then the CANA got the PI of fractures. So we were closely looking into the safety and tolerability data. Something is seriously wrong. So this is a look into the adverse event. In morning, Dr. Del Prato was looking into this data. What happened in terms of adverse event? Hardly you find any difference in terms of adverse event into placebo or empagliflozin 10 or 25 milligram, and I will come into little bit details about specific issues. What is important to note here is the patient, those who are taking a confirmed hypoglycemic agent, and whether they develop a severe hypoglycemia requiring assistance. So this is the patients who are getting a hypoglycemic agent requiring any assistance. See hardly any difference between the placebo arm or the empagliflozin 2 arm. They were suggesting and reinforcing the fact that SGLT2 inhibitor or empagliflozin do not provoke hypoglycemia, even if you combined with a potent oral hypoglycemic agent. And the same story was repeated with the insulin here. You look into this data again, if you look into severe hypoglycemia on the patients, remember 50% of the patients were taking insulin in a dose of more than 50 units per day. And then addition of empagliflozin into different dose could not lead to potentiation of hypoglycemia. Again, they are reinforcing that these drugs do not cause hypoglycemia per se, even if you add with insulin or sulfonylurea. Now, the issue about genitourinary infections, very fascinating data. Earlier we had knowledge that these drugs increases even urinary tract infections. Genital infection was well known to us. But what about the UTI? Because there were several trials conducted head-to-head with DPP-4 inhibitor, and there was no difference between a DPP-4 and SGLT2 in terms of UTI, and that was surprising. Interestingly, in this 3.1 year longer trial, and there was no difference in UTI versus a placebo versus empagliflozin arm. That was very fascinating to understand that, in contrast to the common sense that this drug would be prone to cause UTI, in this particular trial, they could not find any increase in UTI. But the note of caution that this is a randomized controlled trial, real life scenario might be a different scenario. What about the complicated UTI? So many people might think that if there was UTI, what about the pyelonephritis? There is no difference. See here, no difference in placebo versus the empagliflozin, whether it is urosepsis or a complicated urinary tract infections. But then, if you look into genital infections, it was 4 to 5 times higher. They were suggesting that these drugs are more prone to cause genital infections, which we all know, and that was predominantly derived from higher incidence in female compared to male. So that was one known fact about SGLT2 inhibitor, and in this case empagliflozin. What about the other adverse event of potential interest? And we were keenly looking into the DKA data. And I was very interested because I just reviewed the literature on diabetic ketoacidosis, and which is under publications by 7-10 days, it will be published now. So I was looking into these data on DKA, what happened to the DKA with empagliflozin over 3.1 years. Very fascinating data. Before this trial, I still believe that SGLT2 inhibitor does have a potential to cause DKA, even if you choose a right patient. Forget about the type 1 diabetes or patients with a cannula failure and infections. The molecule may have some potential to generate or potentiate DKA. But after this particular trial, I was fascinated to see that there was hardly any difference in terms of DKA over 3.1 years. So this was about DKA. Let's look into the fracture data. So we were also keen about knowing what happens to the fracture data, because immediately prior to this trial, canagliflozin had a PI from US FDA that this drug increases bone fractures. And see here, over 3.1 years, there was no difference in the bone fractures with empagliflozin compared to the placebo. Remember, in the canagliflozin trial mandated by US FDA in elderly people, the trial was only for 2 years, and the canagliflozin was associated with increase in the fractures. Okay, so and in this particular trial, over 3.1 years, we could not find any increase in fractures with empagliflozin. So whether it is a molecule difference or it is a, it's a class effect, we still do not know. To my knowledge, empagliflozin at least could not show any increase in fracture, where we do have the data about canagliflozin. Now people ask about what happens to the electrolytes. Everybody is concerned about electrolytes because this drug has a potential to cause diuresis, and in fact it is osmotic diuretics. See, even creatinine and EGFR changes, because initially we learned that SGLT2 inhibitor temporarily reduce the EGFR, which comes to the baseline by 1 and 1.5 months. But in this particular trial, see, there is no difference in EGFR over 3.1 year. There is no deterioration of further in creatinine level over 3.1 years. They were suggesting that this molecule do not do any harm to kidney. And we will see through other trials like Canvas is doing, Credence trial is doing with canagliflozin, and Canvas R is there. Even empagliflozin's renal outcome data is separately assessed, and we'll be able to know what happened to albuminuria component. But looking into the electrolytes, whether it's a sodium or potassium, there was no difference in the placebo arm over empagliflozin, any dose 10 or 25 milligram. Well, so I'm done here, and I would invite Professor Del Prato and Dr. Neglu to continue further.
Thank you, AK, for your nice comment. Dr. Professor Stefano Del Prato is a professor of endocrinology and metabolism in the School of Medicine at the University of Pisa and Italy, and the chief of the section of diabetes in the University of Pisa, Italy. Del Prato's main interest is in the pathophysiology of diabetes and the therapy in diabetes, especially in the reference to insulin resistance. Dr. Del Prato has published more than 500 articles in the various journals, national and international, and he was the vice president of the EASD for the period of 2011 to 2014. Request Dr. Del Prato to speak on implications to clinical practice and possible mechanisms, and he'll continue further for next 10 minutes for the critical comments of the EMPA REG outcome study. Over to you, sir.
Thank you very much. I'm probably going to put everything together, implication and so on, so as to leave more time for the discussion. Let me first of all say that I'm really very honored to join a very much esteemed faculty for this discussion. And I think that everyone has been struck with the result of the EMPA REG. I understand that many of you were in Stockholm, and I think that you will remember the spontaneous round of applause that really welcomed some of the results. And I think this is the best sign of something. It was a sign of a relief. Finally, we got something, isn't it? However, as it has been said, good things, good results are very well welcome, but we also like to try to digest them and to see whether there is any further question that we need to answer or that we would like to answer. So the results are very positive. You have heard from Dr. Singh this incredible changes, 38% reduction in the risk of mortality. Not talking about small things, we're talking about mortality. It is survival. This is fantastic. But let's put the things in the right perspective. Where is this and the other study coming from? What was the reason for doing this study? Was that a genuine reason to try to prove that there was an advantage? We're lucky to have an advantage, but it was not really the main reason for the study. Not this and not the other studies. You may remember that after the big discussion about rosiglitazone and the Steven Nissen meta-analysis claiming that rosiglitazone was associated with increased risk of mortality, the FDA decided to put some regulation on the opening to the market for new anti-diabetes drugs. And what I said, all right, guys, you do your development registration studies, okay? Then you put everything together, and you have to convince me that you are in the right side in terms of the cardiovascular safety of these drugs. In fact, what you have to do a meta-analysis, and if you can show me that that you are actually a superiority and your upper limit of confidence is below 1, which is by definition superiority, or if you have a non-inferiority, but with an upper limit of confidence, 95%, below 1.3, then I'm happy, me, FDA, I'm happy, all right? And you may not be required, may not. It's not that you are not, may not be required to do a cardiovascular safety study. If you do your meta-analysis and you come up with a non-inferiority, but your upper limit is above 1.3, then you have to do a cardiovascular safety. And if you do your analysis and you end up that you have inferiority and your upper limit is above 1.3 and actually above 1.8, in that case, your drug is not approved. In other words, your drug is kaput. Okay? So this is the scenario. So now you can imagine, because this is a big money also involved. All right? So all the studies that have been developed then have been developed particularly to satisfy the need of the FDA to prove safety of new anti-diabetes agents. And you can appreciate what was the impact for that. Because I think that we have been aware of the cardiovascular risk in diabetes since a long time. The first cardiovascular outcome trial in diabetes was actually run in the 60s, the UGDP. You may remember that. So we were well aware of that. And yet, till 2008, the total number of people that have been recruited in cardiovascular studies is this number here. Okay, it's a lot of them. But see what happened after the FDA requirement. And what is the projection for the number of people that are going to be recruited in cardiovascular outcome trials? I think that there is a major difference there. And as an outcome of that, we already had some results. We had the SAVOR-TIMI and the EXAMINE, and then we had, last June, the TICOS and ELIXA. So what were the results of these trials here? You know that very well, very quickly, because you are very familiar with this data. Now what you can see here, EXAMINE, and again, it has been pointed out very nicely and very rightly and very appropriate manner by Professor Singh that that this population are different population, which also is something that to keep in mind in interpreting the EMPA REG data as well. EXAMINE people with a very recent acute coronary syndrome, acute event, between 15 and 90 days before, okay? And you can see here in these very vulnerable patients, no signal for cardiovascular risk, no signal for improvement. Now you go to SAVOR-TIMI, it's a mixed bag because they had 50% of them with some cardiovascular events in their history, and the remaining of that high cardiovascular risk as indicated by the usual cardiovascular risk factors. Okay, and again, the two lines are just one on the top of the other. All right, safe is a safe treatment. It's not providing us with anything very much. Then TICOS. TICOS, again, same story. And TICOS now is a different population again because 100% of them had a cardiovascular events in their history. And even in this population, safe. So what's the difference between the three studies? None, unless you want to address your attention on the heart failure story. And this is still an open question to be addressed because, as you may remember very well, the heart failure hospitalization for heart failure was increased, although these people were not loaded with an increased risk of mortality. It was just hospitalization. And there was a sort of a signal for EXAMINE, but we know that in these people, heart failure is a very common event after an acute myocardial infarction. And TICOS, no signal at all. And then if you just combine everything, there is a little bit of a sign, and with a test for heterogeneity, which is at the limit for the significance. So what is going on there, we don't know. But keep in mind, because the heart failure may turn out to be a key of interpretation of many of these results here. Then, as I already discussed, is that the heart failure an issue for the DPP4? Because DPP4, as we know, is an enzyme that is chopping down a number of different peptides, GLP-1, but also GIP, but also BNP, but also PYNY, and so on and so forth. So Could that be that the inhibition of DPP4 may lead to a different array of peptides that may have an effect? We don't know. Or maybe it's just the GLP-1 that goes up and may have an effect on the heart. Okay? So the first data we have is from ELIXA, the cardiovascular outcome trial on a GLP-1 receptor agonist. It's a long story, but it's very simple to read it, because if you look at the ZAR ratio, 0.98, 1, 1.1, 1.2, 1.96, 0.97 for cardiovascular mortality and so on and so forth. So everything is right on top of the unity, so no signal. So what has been concluded? What could be the conclusion on this, and what has been concluded at that point? So the conclusion, and I'm just referring because the published data are on the DPP4, the ELIXA has not yet appeared on print as a paper. When added to standard of care, and this is important to remember also in interpreting the results of the studies, is on top of standard of care, which means that in India, there may be some standard of care, in another country, a different one, whatever it is, not better or different, could be different. But all the investigators have been requested to adhere to their local guidelines of a standard of care of people with a high cardiovascular risk. When this happens and DPP4 are added on top of that, the DPP4 neither reduce nor increase the risk of the primary composite endpoint of cardiovascular death, myocardial infarction, and ischemic stroke. Now, what's your impression on this? So what's your conclusion? What do you bring home? I mean, what I bring home is that we may have half a full and half empty glass. Yeah, it depends on your mood, okay? Or depends if you are a diabetologist or maybe a cardiologist. Because if you are a cardiologist, and I don't want to be at all, offensive to any cardiologist, of course, okay? But if you're a cardiologist and if to write a commentary on the New England Journal of Medicine, you come up and say, the optimal approach to reduction of cardiovascular risk in diabetes should focus on aggressive management of the standard cardiovascular risk factors rather than on intensive glycemic control, which I think it is not appropriate for a very simple reason that has been alluded to by Professor Singh. These are equipoise studies. These are not investigating whether significant reduction in fasting glucose levels do have an impact on cardiovascular outcomes. What is this data, these trials have been designed to, is to prove that your drug is as good as placebo in not generating risk for the patients. So I think that this conclusion is not really appropriate. In this scenario, we got the results of the EMPA REG outcome, and you have already heard them. So EMPA reduced hospitalization for heart failure by 35%. It's not peanuts, isn't it? Empagliflozin reduced cardiovascular death by 38%. Empagliflozin improved survival by reducing all-cause mortality by 32%. It looks to me like a sort of a miracle more than a result. It's too good to be true, you could think. And in fact, I can tell you that the investigators really are looking for the results of the other cardiovascular outcome trial with the SGLT2, because these are amazingly good. Okay? So one natural question that comes to say, all right, if these are the results, and if you put that results in the perspective of what has been the history of trying to reduce the cardiovascular risk in diabetic individuals, this is even more amazing, because remember, everything started off with the statin in the 4S. But I would say, allow me to be a little bit, provocative. It was easy. Because cardiovascular risk at that time what was that? So there was plenty of room, and we know that cholesterol is important. It's not to deny the importance of cholesterol, but it was to some extent easier to prove that you have to treat 30 individuals to avoid one death for cardiovascular reasons. Okay? And it was so good results that what we did, we started to treat our patients with statins, which is most appropriate. And in fact, a few years later, 30% of the population that has been recruited in another cardiovascular protective trial, HOPE, looking at the effect on blood pressure, were already on statins. So 30%, you say, oh, now we'll say for us 30% is bad number, isn't it? It's too low. Doesn't make any sense. But you have to think back 15 years ago when the study was started. So that was a major change from here to here. Yet, by reducing blood pressure, using an AC inhibitor, ramipril, what was shown is that you have to treat 56 patients to avoid one death because of a cardiovascular cause. And the result was so good that what we have learned, that type 2 diabetic individuals are a very high risk of cardiovascular disease, and because of that, they all have to be on statins and to have to be on AC inhibition if they just have a little bit of an increase in their blood pressure. Okay? And in fact, the people that are being recruited into the EMPA REG, as has been already pointed out, look at this, more than 75% on statin. How many of your patients are on statins? Do you achieve a 75%? I don't achieve a 75%. So I think that we should really congratulate these investigators for the background treatment. Look in terms of the AC inhibitors, more than 80%. And if you just look also at the use of the antiplatelets, again, that's kind of the same number of the same percentage. So this is very highly protected population. In this highly protected population, using a drug now, empagliflozin, and you got to treat 25 patients for 5 years to avoid one person to die because of cardiovascular disease. So again, amazing. So if you look at this data and you just think about before what I showed you before, I think that your glass that was half empty, half full, now really is completely full. Okay? And the next question is, what's magic about this? So what's make the difference? Now, you can think about many potential differences. We just alluded before that, for instance, for the DPP-4, there were different population. Could it be that it's the different population that have been studied? Now, remember, SAVOR, mixed bag, the examine, the most vulnerable one, and the TCOS, the one, all of them with the prior history. So the TCOS, to some extent, is the one that is much closer to the population that have been enrolled into the EMPA REG. So let's make a little bit of a comparison, just to see whether different results, TCOS that was safe, but not superior, and EMPA that was superior. So population by the selection criteria, all right, in the EMPA REG, a little bit wider range for A1C for the population to be recruited, a slightly more narrow for TCOS. Now, BMI, the same thing, this is not being specified here. But what I like to point it out to you, that besides what is the definition, in both population, 100% of the individuals that have been recruited had a prior history of cardiovascular events. So was there any difference between these patients? Here is the main features of the two populations. Age, quite comparable. There's a 3-year difference, but if there's anything worse, it's go against the EMPA REG, because the strongest predictor for survival is age, as far as I know, isn't it? All right? So then diabetes duration. This is my personal estimate, just going by and large, although I totally agree that there's a diversity within the population. But by and large, most likely, the average duration of diabetes in the EMPA REG is superimposable, is comparable to the one of TCOS. A1C, slightly worse with EMPA REG as compared to TCOS. Strange if you think that the EMPA REG had a narrower range for selection as compared to TCOS, but whatever. If any, this is worse for TCOS to start with, for EMPA REG to start with as compared to TCOS. Percentage of people on aspirin, comparable. On statins, comparable. On beta blockers, comparable. On ACE inhibitors, receptor antagonists, comparable. So there is not really a difference in the population that really comes up, stands up as a major difference. So if it is not the population, what else is there to account for the difference? Now, one thing that you can think of is that maybe one molecule have a specific effect. This is just a summary of all the available data, the studies, trials that have been evaluated, the impact of a specific treatment, and only a couple of them had a signal for a reduction in cardiovascular outcomes. And that is metformin, and I say they have a signal because metformin, yes, is statistically significant, but would you today buy a study based on 340 people? I think that would be, it would generate at least a number of questions, isn't it? Yeah. Okay. Now, anyhow, but metformin, we are pretty confident metformin. I'll say, I think metformin is a great drug. But, you know, in terms of demonstration of the effect, it was, okay, good, but not as good as we like to. Proactive, you know all the story about this, and then we have all these results here. So, what is about these different drugs, and what is about the drug that we are discussing now, the empagliflozin? Now, one of the concepts that has been brought about in terms of a potential cardioprotection from metformin is that metformin may provide us with some cardioprotection because yes, it reduces glucose levels, but it has pleiotropic effect, a little bit on lipids, a little bit on that, a little bit on this, and so on and so forth. So the idea that a drug that may have ancillary action may provide advantages is something that makes the drug of interest. Although we know, think about the rosiglitazone, that not always what is there as a potential effect may translate necessarily into a protection. However, what has been claimed for empagliflozin is an array of different effects, central of which, of course, is the glucose concentration improvement in glycemic control. So what I like to do with you now is a very simple exercise, and to ask ourselves, are there any of these actions that may have accounted for the improvement in the cardiovascular mortality that we have been recorded in the EMPA REG? Now, the first thing, we're talking about glucose, and we already discussed, is an equipoise study, so does it make any sense? Yet, someone will say, yeah, you're right, it's an equipoise study, but there is a difference there. All right? For the first year, there was actually quite a nice difference. And if you just look at the registration data, this is even better than registration data to some extent, isn't it? So you have close to 1% reduction in 1C. And then you got, this difference that stayed there. So you may ask yourself, all right, so maybe a little bit of glucose, a little bit of touch of glucose, it's of good in reducing the cardiovascular outcome. Now, I know that you are already convinced this is not the case, but just for the sake of the discussion, let's see how can we use to interpret the results. To my eyes, what I like to propose to you, which is potentially the key of interpretation, is not the overall reduction in cardiovascular risk, but actually is the time course of the reduction. And now, if you look carefully, and this has been already addressed at the time of the presentation in Stockholm, if you carefully looked at the initial part of the curve, now you can appreciate, look at this, that here, after the first couple of months, you already have an opening of the two curves. So this is a very rapid effect. Now, let's assume this is glucose. All right, let's assume for a moment this glucose. What do we know about glucose? UKPDS. Now, it took 20 years for sulfonylurea and insulin to prove there is a difference in the two curves. It's better with metformin, but again, it took years before you could see something. So glucose is an unlikely explanation for this rapid improvement in cardiovascular mortality and in the outcome that reported by the EMPA REG. So, and the other interesting thing is what we know about the potential implication of good glycemic control on the cardiovascular outcome. Now, this is just a table that is reporting a conservative list of meta-analysis, intervention trials, and so on, looking at the effect of intensive glycemic control on cardiovascular risk. And what you can see here, if there is the red numbers here, is the significant numbers. And this is reduction on non-fatal myocardial infarction. And look at this. And this number seems to be a sort of a magic number. 0.85, 0.83, 84, 86, 84, 85, 86, 87, 85 is always the same number. And what about cardiovascular mortality? 1, 1, 1, 1, 1, 1, 1, 1. Zero effect. What happened in the EMPA REG? If this is the glucose effect, if this would be something like that in the EMPA REG, you would assume that something goes along the same line, isn't it? Which is not the case, because the difference here, look at this, non-fatal myocardial infarction is not significant. It's close by, 0.87. Again, it looks like, we're going around that number there, but the major difference is this one here. So if you want to read it in a very naive and superficial manner, the empagliflozin in the EMPA REG doesn't prevent you to have a myocardial infarction. However, it gives you a better opportunity to survive out of that myocardial infarction. Okay? So that's the major difference. So that means that other things are maybe involved rather than glucose. Could it be the body weight? Now, there's been a lot of discussion about the body weight. For instance, when interpreting the results of the VADT, the Accord, people were increasing their body weight. Could it be that one? There is a decline in the body weight, is something like 3 kilos. It is sustained over the time. Is that sufficient? Now, as you know very well now, there's a big discussion about the obesity paradox. So according to someone, if you have this kind of BMI or body weight, you may actually be sort of protected. Anyhow, reducing body weight may be helpful. However, what we know in terms of reduction of body weight, as it has been obtained and has been already alluded to by Professor Parving just an hour ago, you do reduce the body weight in the look-ahead trials, and you have no effect on overall cardiovascular mortality and mortality. So it's unlikely that these 3 kilograms body weight are going to account for that huge reduction in the risk that has been reported in the EMPA REG. Now, the other thing is blood pressure, and blood pressure is a powerful cardiovascular risk factor, of course. And here you can see, and I think this is amazing. I think that this kind of reduction in blood pressure is similar to the reduction in blood pressure that you can observe in intervention trials based on antihypertensive treatment. 4 to 5 millimeters of mercury, and is sustained over the time. It stays there for all the 3 years of the follow-up. This is amazing. Is that then a potential explanation for that? That could be a contribution. However, let me once again remind you how quick was the separation of the curves. And let's see what happens in other intervention trials using antihypertensive agents, like for instance in the micro-HOPE. Now, this is significant, very much, a potential effect, a potent effect on cardiovascular risk. However, if you look at the time when the curves start to open up, you can see that it's around 200 days. So it may be there, but it's not there yet. It looks like the EMPA REG is much quicker than that. So there must be something else. So the other option is none of them per se may be sufficient to give you this reduction. So what could it be then? Now, it could be that since the fact that the empagliflozin had an effect on the on the blood pressure, had an effect on the body weight, and an effect on the glycemic control, that what you have is a sort of a polypill. All right? Something that is good for one thing, another thing, and another thing again. So what you do a steno trial. And we know that steno trial multifactorial has been very effective. However, again, the opening of the curves may not be the same. So what I like to propose to you as a key of interpreting the data is just to focus on the heart failure. Do you remember how quick the 2 curves open up? Look at what happens for the heart failure, hospitalization. It's even quicker. So from a temporal point of view, the 2 things really overlaps. That should bring us to consider what's going on there and what could be the effect, why the empagliflozin is reducing heart failure hospitalization. So you can come up with a number of potential explanations. You could claim because there is a reduced myocardial ischemia infarction, so you have a better muscle, heart muscle, that is there to do this job, okay? And which is not the case, because we have already pointed out that the myocardial infarction is not significantly reduced. It could be a reduction in arrhythmias, such as atrial fibrillation. It has been reported, by the way, in some of the tables available, and this doesn't seem to be the case, although there may be some more to understand, because we don't know exactly what's going on locally in terms of potassium levels and so on that may change the excitatory status of the heart muscle cell. It could be some tissue remodeling, and this morning you probably heard Professor Reardon giving you some indication of how the SGLT2, at least in the preclinical data, have been associated with some data suggesting a reduction in interstitial fibrosis and a reduction in the macrophages infiltration in animal that have been treated with empagliflozin. Could that be the case? We don't know. This is very preclinical, so we don't know. One thing that we need to take into account with respect to the heart failure maybe is the improved left ventricular loading conditions that may be associated or generated by reduction in arterial venous tone, or both of them, and a reduction in intravascular volume. And there is the possibility that empagliflozin works like that. We know that it exerts a little diuretic effect. And as Professor Singh pointed out, if you look at the clinical parameters and you focus on the CREAT, now you can see here there is a difference. This is one of the few things that has been different. Look at this. The change in CREAT with EMPA 10 milligram or 25 from the starting to the end is 5 points as compared to 1. So there is a reduction in the circulating volume, which has been heralded by this. So could that be the explanation? We don't know, but there is one thing that you can consider. Now, what we know about studies using a diuretic effect. Now, this is an example of these intervention trials that using eplerenone. Of course, there are other implications here because this is a mineralocorticoid antagonist, but there is also a diuretic effect. And what you can see here, again, in terms of heart failure, very much similar to what we have observed in the EMPA REG. Although there is a difference with the EMPA REG. Look at what happens in terms of the mortality. In the EMPA REG, these two pictures here, these two sets of lines, goes on the same way. They opens up. Here, you have a quick opening up of the curves, yet you have delayed response in terms of cardiovascular mortality. What does this mean? What I would like to suggest to you that the volume, the hemodynamic implication of EMPA REG may provide you with an explanation, but maybe there may be something else. And what is this something else? I don't know. There's only one thing that I'd like to point it out to you, that we do not understand. And I think that there is a lot that still we need to understand on the physiology at the level of the kidney that may be activated by empagliflozin. There has been something that has been discussed during this meeting, like, for instance, the tubular glomerular feedback, the activation of the angiotensin cascade, and so on and so forth, the renin-angiotensin, okay? But let me just give you an example of what little we still understood of what's going on. I already showed these slides, in the previous session. Now, here you see there is patients with a certain degree of impairment in the kidney function as indicated by the GFR, and this is an even lower GFR range. And what you can expect, because of a less filtration, less glucose is there to be reabsorbed, so less glucose can be excreted through the urine, and you can see here that there is a significant impairment or reduction in the hypoglycemic or hyperglycemic effect. Yet, in spite of this, people still lose weight. People still have a reduction in blood pressure. This is 4 millimeters of mercury. It's not very much different from what has been observed in the EMPA REG. So to me, it suggests that we got to learn more. There may be something else that we do not understand that may allow us to explain these results. So the other thing important I'd like to bring up which has been already done, is what the EMPA REG not only has provided us with some advantage, but I think it has put us in a very relaxed condition with respect to the safety, because this is just the list of the safety issues. There was no increase in the incidence of hypoglycemia, renal impairment, urinary tract infection, volume-related side effects, bone fracture, thromboembolic events, forgive me for the typo, low incidence of DKA, this wasn't a rush preparation for this, serious adverse events and adverse events leading to drug discontinuation. Yes, it was slightly, though not significantly higher, sorry for that again, in the empagliflozin. Genital infection really was the only signal there. But I think it's worth to have a genital infection if you do reduce by 38% the cardiovascular mortality. So in summary, the empagliflozin has reduced the 3-point MACE by 14%, has been associated with a number of efficacy signals, and the only thing that is you have to pay for that is an increase in the genital infection. So what else should we ask ourselves? This is my question, but not necessarily is the only question. For instance, one question that I didn't think about, but it came out from the discussion earlier on. Because of this data, is this a treatment that we may foresee in the future after an acute event? We don't know, but that is an open question, isn't it? And again, will EMPA produce similar cardiovascular benefit in younger group of diabetic patients with a short duration of disease and without clinical evidence of cardiovascular disease? Or is just in this population? And again, maybe the positive results of EMPA REG be driven by a specific subgroup with unique cardiovascular abnormalities. I mentioned to you the people with a reduced kidney function. Are there a burden, or maybe are those that for some reason or no reason are providing an increased benefit? We don't know. And again, are any beneficial effects observed with EMPA unique to EMPA, or could be considered a class effect? And again, we have more trials going on, of course, but again, those trials will be with different populations, which to my eyes is good, because it allowed me to opening up the investigation and the different class of patients that I'm considering for protection. And finally, the implication, this is what Elsa Gerstein in the excellent commentary he came up with. So empagliflozin confers both non-glycemic and glycemic benefits. It may become first-line therapy for middle-aged people with type 2 diabetes at the time being, because this is where the evidence is there. The cardioprotective effect requires explanatory studies, may apply to others with dysglycemia, and it should be tested in a number of individuals, like for instance the one here, the one that we mentioned, the post-acute syndrome. And there is one more question, because improving glycemic control, reduction in blood pressure, a little bit of an effect on the body weight, and this is important for macrovascular complication. But as far as I know, it could be good also for microvascular complication. And that's something that we needed to explore. So this is my view and my interpretation of the results, which is not actually an interpretation, but it's my own thought and my own question and unanswered question, but I'm really more than happy to hear your opinion.
Thank you. Thank you to Professor Del Prato for an excellent overview and the critical comments on the study. This house is open for questions. Anybody has questions, they can answer. Yeah, Vijay.
Well, one of the speakers did say that statistics is a science which you can twist. I would like to add something to this. Statistics is a very illusionary science, and we saw a lot of illusions which might be a reality. I'm not saying that they are just illusions. But the last of the few slides, because we saw around more than maybe 200, 300 slides. I don't remember all of them, but the third slide from the last, you were talking about some of the questions which have not been answered, like the development of coronary heart disease in diabetics who have not been diagnosed to have coronary heart disease at the time of inclusion. So I would like to ask a question regarding this. There were patients in the study who were having coronary heart disease, those who were having hypertension, and there were patients who were not having both of them. So in the study, the physiology of the heart, how was it assessed to know whether some of them were developing coronary artery disease, or those who already had coronary artery disease, the disease was progressing?
I cannot give you a specific answer because I'm not an investigator of the EMPA REG trial. However, what I can tell you is that
What was missing is a physiological assessment of the cardiac status.
But I totally agree with you. You know, these kind of results are going to trigger more investigations. And I think that it's not feasible to do physiological or pathophysiological study in 7,000 individuals. So you got this data now, and now what you
I
need
don't
to
think
do...
doing a stress test or a treadmill testing was an impossible thing.
I'm with you, but you know, you're not the, I'm not the one paying for that, you know. And if you have to know this kind of studies, that's the data. So,
Professor, I think you could not get the question rightly. So he's asking what was the difference between patients having a coronary artery disease and hypertension versus who doesn't have. Everybody had coronary artery disease or any cardiovascular disease. If the patient doesn't have any of this cardiovascular disease, they were not recruited into the trial.
So I'm asking the same thing. If they were already having coronary artery disease,
Right.
which was probably in the stage of chronic stable angina, whatever was their exercise tolerance, was it assessed periodically to say whether the disease was progressing or was stable?
Well, I think we need to wait on all this data. We don't have the result for now.
No. In all this cardiovascular event, during the course of a time, if patient develops CV events, as a part of standard of care, they would be evaluated. So if somebody got an angina and got hospitalized,
That's not how we do in chronic stable diabetes.
but
if we assess the patient, if patient develops the symptoms for no reason, somebody is not subjected to coronary angiography and then an
Coronary angiography is not a physiological test or for the physiology.
What do we do?
Excuse me. Let me. One thing is the clinical practice. One thing is running a study like this. Okay. So one thing that I think I would agree 100% with you. That would be wonderful to have all these informations. But I think, you know, that it's not possible in one... Let me finish, please. In a clinical study to collect all the information. For instance, we do not have, at least for the moment, levels of BNP, levels of troponin, for instance, in these individuals. Maybe we will have in the future. But what I think is important here is in a randomized clinical trial, double-blind, double-dummy, to have this kind of decline. Now, whether we can explain on the basis of the pathophysiological condition, on the heart function, on any other features, that is not possible at the moment. That will be investigated in specific studies, I believe. But for the simple fact that we do not have this information, I would really deny the results of a single study with such a large impact as compared to a number of studies that have not come up with any single information along that line.
Yes, your question.
I feel that you need to study these patients. What happened to ischemic to begin with in China, or they have coronary artery disease. What happened to the progress of these diseases also?
Because there's a history of progression of the disease.
What happened to these?
Again, I mean,
Where they were assessed, analyzed time and again.
It's a nice question, but
the same thing is
trial
applicable to
cannot
heart failure.
answer this question. The primary endpoint, so in other words, the observed outcomes are the one predefined by the protocol.
Right. Dr. Neglur, I think we are missing the link. The primary outcome of the study was to look for 3P and 4P. Now when results are out, you are trying to know much more data which was not the actually objective of the trial.
It's a pity,
So, yeah, simple.
No, but here we have a patient, we said 1 out of 3 you prevent heart disease. There is no much outcome in acute coronary events, no much difference in the acute stroke events. These two are almost in a similar process. They can go in a different biologically, but they have a common outcome as a death. On one hand, you're saying there's a good outcome, On the other hand, say we say that there is no good stroke outcome or there is no good outcome in the acute coronary events. So how it is possible to digest?
But let me tell you, let me give you my explanation, as I already alluded to. The treatment is not preventing the progression of the atherosclerotic process, assuming that's the only thing, okay? And because of that, the rate of myocardial infarction, non-fatal, is not significantly reduced. Fine, okay? So you can look at that and say, the drug is not good to prevent the myocardial infarction. Yet, if you have a myocardial infarction, you have better chances to survive it.
Let me answer your question. So, your question is very valid. So, if you have got a disconnect between CB death versus non-fatal MI and non-fatal stroke, what was the reason of reduction of CB death? There is answer for that. In fact, there was no reduction in non-fatal MI or a stroke. There was also no reduction in fatal MI or fatal stroke. So, where was the benefit? The benefit was primarily derived from the CB death in a patients who were actually hospitalized for heart failure, number one. Second, the benefit was obtained from sudden cardiac death, from arrhythmias, from pulmonary embolism, maybe because of cardiac catheterizations, for revascularizations. So there was a reason why there was a decrease in the cardiovascular death, but that was not akin to the MI or a stroke, whether it is non-fatal or fatal. So answer is there.
Yeah, it's more of the acute events rather than the atherosclerotic
Correct.
process.
That's why you got the benefit within 3 months.
Yes, but there was no data on arrhythmia, what he mentioned, there's no arrhythmia data. Could it be, as Dr. Shah was saying, the stiffness of the vessels is responsible for the events that occur, or the events were prevented because of that?
For that you need a longer period of time to get a benefit. Yeah.
Yes, that's why I try to address.
What I would like to say is recently we have had the automobile industry facing a problem. You know, the Volkswagen had installed a software which in test conditions
No, right.
and actual field conditions it's failed.
Yeah, true. That happens in the past,
But the Volkswagen was cheating.
Yeah.
All right, this is not cheating as far as we accept randomized clinical trials.
And that's why, Professor, I explained that you can cheat on any statistical data. You cannot cheat on death. That was the point I was trying to make.
That's a hard point.
It's a hard point.
That's one question, Dr. Singh. Dr. Singh, there's one question for you. There's a hematocrit which changed from 41 to 45 in these patients. Is this change in the hematocrit responsive for the excess events of the stroke in these patients?
Well,
Or
this
when they
was,
were assessed?
if you go back to those slides, this was hardly any statistical difference. Whatever the difference you were seeking is just numerical. There was no statistically significant difference in hematocrit in placebo or EMPA 10 or 25 milligram.
Where they were assessed to the disutility index score of the stroke.
Yeah.
Where they were assessed by that?
Oh, I don't know.
But the other thing that may be related to this is that the thromboembolic events
Yes.
have been calculated. There was no difference.
No difference.
So it may be different, if you just look at the brain, of course, but overall there was no difference in the thromboembolic events. And if the crit, if the reduction in volume, the dehydration could play a role, you would expect to have a signal there.
True.
Dr. Shah, one question for you. You had 11,000 patients who were screened before the study. And actually, 7,000 patients were enrolled in the study. Almost half the patients were disqualified. You know what's the reason behind this?
No, this is more of a screening for eligibility. At the same time, these are selected and then subsequently investigated. So if somebody got higher creatinine gets excluded, somebody unwilling to participate, first few weeks was a placebo observational period run.
No, they were dropout patients subsequently. But before,
No, the subsequent was
97%
reducing every stage
retention.
from 7,000 downwards.
retention was 97%. Yeah.
Yeah, they did not consented for opting for undergoing in the study.
So large section of patients dropped out.
3%.
No, not
3%.
No, in the screening. 11,000 were included in the screening and actual study was 7,000.
Dr.
That
Neglur,
means-
you go to the NEJM supplementary tables, you can get the exact reason I think their slides should be there if the questions are coming. Why from 11,700 has been picked up? There is a clear-cut demarcation how many percentage of the patient did not give either consent or were not fit to be recruited in this inclusion criteria. So there is a clear explanation. It doesn't mean that there was something in the dropout rate. Similar happened in the placebo arm. So only 3% was the dropout. Similar between placebo and the empagliflozin arm.
That brings us to, yeah.
I have two questions.
Yeah.
One is, are we limiting the patients who will be subjected to empagliflozin to established coronary artery disease or even in diabetics and early stage of the disease? Number one. And number two is, why is this divergence of when the atherosclerotic process is the same with coronary artery disease as well as strokes? The atherosclerotic process remains the same. Why is this divergence explained? Apart from the hematocrit.
Okay, now the first question was about, sorry, the indication, the indication. I mean,
will we wait for the patient to have
okay,
an established coronary artery disease to have a patient?
I mean, again, I don't think that we, as a community, can answer that question because that will depend on the regulatory agency whether they will give a specific indication for one treatment or another treatment. But of course, I think these results, at the time being, suggest that in the population with the characteristics of the EMPA REG, the empagliflozin treatment is most likely indicated. Whether then the regulatory agency will move away from that and make this even a larger indication, I can't say. This is pure speculation, so I prefer not to answer that question. Now, what could be the reason behind that? I think my view, and it's speculation because there is no data, but you have to keep in mind that diabetes is a disease of macrovascular impairment and microvascular impairment. We know very well that people undergoing the bypass or whatever revascularization process are much less good outcome as compared to the non-diabetic. And the reason for that is the diabetic heart, the microvessel disease in the heart. So I think what we are looking here is a combination of hemodynamic and potentially some effect, metabolic effect that may also have an impact on the function of the heart. But what I think, what I buy for myself, and I would like to hear, my colleagues here, is that the empagliflozin is not really impacting, at least in the first year or so, on the progression of atherosclerosis. It's most likely to be a hemodynamic effect or some other factors that we have not yet identified. And that's what I was trying to allude to when I was suggesting that something may be going on at the level of the kidney.
Yeah, completely agree with you.
So there's one more question, that when you talk of cardiovascular benefit in the anti-diabetic drugs, we have metformin in the UK PDS study, which showed the benefit of CV reduction to the tune of 39%. Though the population was small, the similar benefit we see also in EMPA REG. Is there any head-to-head comparison? Is it possible to have this kind of comparison that between metformin and empagliflozin?
I think that your question is a very good one. And that's exactly the reason why I started off my commentary trying to put everything in the right perspective. Where are these studies coming from? The studies are coming from the request of the FDA to provide specific indications. It's not designed to do a head-to-head study versus other treatments. And in fact, as has been pointed out by Professor Singh, you could use anything you like to control glucose, with the exception of the SGLT2 inhibitors. So it's a mixed bag, but it's mixed bag also in the UK PDS, because remember that the result of the metformin is an intention to treat. Most of these patients, even though there were 340 patients, ended up with other drugs added on. So it is very difficult to really identify what is specific to one drug as compared to another drug. And there is no study designed to that goal as far as I know.
Dr. Neglur, I would give you a provocative answer to this question. The point remains is there is no point comparing between UK PDS trial and EMPA REG outcome because of the fact that EMPA REG outcome, if you see the baseline patients data, 99% had a heart disease, In UK PDS trial, 5% has a baseline heart disease, 95% was free of any cardiovascular disease, number one. In UK PDS trial, less than 2% of the patients were getting a statin. Here you have got a 75 to 80% patients on a statin, RAS blocker and aspirin. Third, the patients recruited in UK PDS 34 with metformin, that magic number of 342, if you do a repeat UK PDS trial, you will never ever get any advantage.
Now I'm just wondering what mechanistically, between the two molecules you consider, so far as the cardioprotection is concerned. Here also we had 75% of the population were on metformin. So they already had that kind of benefit already to begin with.
But that benefit was also in the placebo arm.
Placebo arm, both the arms.
Both arm had got the same arm. Placebo also had a statin, and so if you are getting any advantage, that is over and above a statin, RAS blocker and aspirin.
Oh, that
So
means-
what you may want to do, just coming along your line, just to be very speculative and very, just a sort of an exercise now. What you could also consider is whether the use of empagliflozin has prevented, to some extent, the use of other drugs that may be associated with negative impact. So in other words, may not necessarily be everything good about empagliflozin, but by using empagliflozin, you have to use less insulin, a little bit less of sulfonylurea, and so on and so forth, that may have helped. But this is intrinsic to the nature of these studies. It's very difficult to dissect out. So what we can conclude from this data, and I think that we cannot squeeze out more than what is the study has been designed for, besides, what is a very intriguing discussion like this one, which is always good to have this kind of discussion. But, what we can conclude is that on top of other treatment and on top of the standard of care for cardiovascular protection, the use of empagliflozin, whatever is the mechanism, we don't know what is the mechanism, is associated with these things. Next step, let's figure out the mechanism.
I think there's the last question. Last question already.
So my query is that all patients had average 10 years duration of diabetes and established cardiovascular disease. Now, all the placebo group patients were getting all other anti-diabetic agents, but probably they are not properly adequately stepped up, because 3 years, just my question is, during this 3 years observation period, they are more or less maintained at an HbA1c of 8, which is not accepted as a standard of care in a post 10 years duration diabetics with evidence cardiovascular disease.
Should I answer? Well, I think you are completely misunderstood in the trial. Both the arm was equally poised. Remember, if you look into what happened, the post-trial drugs data, it has not been shown here. If you look into the number of anti-diabetic agent added after the trial, was at least 25% higher compared to the empagliflozin arm. So they were intensively treated to match to the level of empagliflozin, but at the end of the day, they also lacked by 0.3% in the placebo arm. So don't say that they were not up-titrated to the extent. This is mandatory in the US FDA. Yeah, it is there. It is there. I mean, that you need to look into everything.
No, but I think your point is very well taken. However, let me tell you, which other studies we have for intensive treatment of hyperglycemia with an average duration of 10 years. VADT and Accord. What's the result?
22% mortality.
So?
Glucose does
So?
not contribute to the change in mortality with
So-
that much point.
So whatever, I agree with
Glucose
you.
contributes very little, and whatever was added in the other arm probably failed to get still A1C less than 8. So maybe at that stage, insulin treated and every possible drug was on, you increase from 60. Yeah, it could not be, because that makes a resistance. And
But not only that, you also remember that the objective, has been already pointed out, was not to reduce glucose, but to follow the standard of care. So, given
Yes,
that
Ramesh,
point,
quickly, just
you go
take the
back to
mic.
your clinic, okay, and see what is the average A1C over a period of 3 years in the diabetic population. And I bet that in that population is slightly drifting up.
My question is, being such a miracle molecule and no relation with the glycemia, the benefit is unlikely to be glycemia. So any experience or any data with non-diabetic population with similar risk factors?
No study.
You know,
No,
the
sir.
So is
SGLT,
it going to be a next statin?
the SGLT2 inhibitors are not indicated for people with normal glucose.
Diabetes, yes. I think thank you very much for an excellent discussion of more than 90 minutes. I thank Dr. Shelila Kare, Dr. Sanjeev Shah, Dr. Del Prato for giving excellent insight on the EMPA REG outcome study. Thank you very much.